Looking at these abdominal radiographs, the first thing that catches my eye are the dilated loops of small bowel, mostly concentrated on the left side. It's clear that we're dealing with an obstruction, but there's more to the story. As I continue scanning the image, I notice an ovoid, calcified opacity sitting in the left lower pelvis. It's strikingly dense and has that classic lamellated appearance, which is highly suggestive of a gallstone. It seems almost out of place, considering we expect to see this in the biliary tree, but here it is, further along in the gastrointestinal tract. So, where did this gallstone come from? It likely passed through a fistula that formed between the gallbladder and the small bowel due to chronic inflammation or infection, allowing the stone to travel down and lodge itself, causing obstruction. At this point, I'm leaning heavily towards a diagnosis of gallstone ileus, a condition where a large gallstone obstructs the bowel, but let's be thorough. One key thing we don't see here is Wriggler's sign. There's no evidence of free gas under the diaphragm, which would indicate perforation. That's a relief, but we must still consider the possibility of a hidden perforation, especially since there are a few small gas foci near the liver that give me pause. An erect chest radiograph would help clarify this and rule out any free air. The absence of perforation here doesn't diminish the severity of the situation, as gallstone ileus often requires surgical intervention to relieve the obstruction. What else could this be? In terms of differential diagnoses, I'd consider other causes of bowel obstruction. A large obstructing tumor could present similarly with dilated loops of bowel, but the presence of a calcified opacity shifts my thinking away from that. Phleboliths, or calcified mesenteric lymph nodes, could potentially mimic the appearance of a gallstone on plain films, but they wouldn't explain the obstructive pattern seen here. Another thought might be a calcified enterolith from a long-standing diverticular disease, but the lamellated appearance of the opacity and the clinical scenario fit much better with a gallstone. Now, if I were asked about why there's no free gas, despite suspecting gallstone ileus, I'd point out that in gallstone ileus, the stone passes through a cholecystoenteric fistula, allowing it to enter the bowel without necessarily causing perforation. Free gas is not always present in these cases. And if someone asked about the classic triad associated with gallstone ileus, I'd say we look for 3 features: small bowel obstruction, pneumobilia, air in the biliary tree, and the presence of an ectopic gallstone. Not every case will show all 3, though, so it's essential to piece the puzzle together based on what we do see. As for the next steps, while a CT scan could help confirm the diagnosis, identify the location of the obstruction, and guide surgical management, sometimes the findings on plain radiographs are compelling enough to discuss urgent intervention with the surgical team. In conclusion, while this case is quite telling with the evidence at hand, never hesitate to follow through with a clear and open conversation with your clinical team. And of course, stay sharp by subscribing to Radiology Made Easy. It's your go-to resource for decoding tricky cases just like this one.